Well, Keynote 564 is an adjuvant trial using the immune checkpoint inhibitor pembrolizumab in high-risk renal cell carcinoma after curative intended surgery. And we know from some years ago and the subsequent EMA approval of the pembrolizumab for this setting that the primary endpoint of disease-free survival was significantly improved and the risk of relapse and recurrence was reduced by 1 year of adjuvant pembrolizumab in the, well, let's say trial-defined risk criteria group of intermediate high risk and the so-called M1 NED risk group. M1 NED is after metastasectomy, no evidence of disease, high risk T4 node positive patients, and the intermediate high risk is T2 patients of grading 3, 4, and all the T3 subgroup. And now this trial answered the question as it reached its secondary endpoint of overall survival, and the overall survival was significantly improved by the pembrolizumab treatment, and this data was presented earlier this year at the ASCO GU meeting. It's fully published in the New England Journal of Medicine, but it's a very important result because I think in the adjuvant situation we have two key questions. Can we prevent the relapse, and can we prolong overall survival? And the overall survival prolongation is of importance because it answers us the question, should we do an early treatment or should we do a late treatment once the patient relapses? Well, the overall survival was improved by 32%. The hazard ratio was 0.68 with an absolute difference of 5%. So what does that mean for the clinical practice? I mean, of course, we have a lot of patients who are just cured by surgery, taking out the primary kidney tumor in the non-metastatic setting. And the 5-year DFS rate was more than 70% with just surgery alone. And the overall survival rate 86% after 4 years. So this means, yes, surgery can cure, but there is a certain amount of patients who is at risk of relapse and who has its benefit in terms of the DFS, the result earlier observed, and now the overall survival benefit. What we do need for the patient selection, of course, is always, well, the balance between the risk and the harms. We know immunotherapy demonstrated to prolong the overall survival, but it could have toxicity. Grade 3, 4 adverse event rate was 18% in the setting. And this leads at the end to an individual risk constellation, I think, for the clinical practice. If you counsel the patient, you take the patients as defined by the trial criteria, but as every patient who is eligible, it's an individual discussion if this patient should receive 1 year of pembrolizumab. And this relates, of course, to the question, what is actually missing in the setting? So all risk stratification is based on the TNM categories and the TNM staging. And we do miss molecular markers, predefined molecular markers. We need, let's say, the plus in addition to the TNM classification system for the risk stratification. And we also learned, and maybe so beyond the Keynote 564 trial, relating to a retrospective analysis of emotional 10, that kidney injury molecule 1 could be one of these prognostic and predictive biomarkers. But I think there's more to come, and let's finish that setting that we have new trial approaches, specifically with a personalized mRNA vaccine targeting neoantigens in combination with the checkpoint inhibitors in this patient population, which is definitely in need of therapy.